Hi students, hope you are all doing good. Now in this video, we are going to discuss about what is miscarriage and what are the various types of miscarriage and management, right? So, miscarriage. In other words, we can call this as abortion or pregnancy loss. Okay? And remember, abortions are defined, okay, by using two parameters, namely gestational age and weight of the fetus. Okay. The gestational age should be less than 20 weeks and the weight of the fetus should be less than 500 grams. Okay. And at this stage when there is a pregnancy loss, okay, then it will be called as miscarriage or abortions, right? And abortions can be further classified as spontaneous abortions or induced abortions. Okay. Spontaneous abortions can be isolated losses or it can be a recurrent loss, and induced abortions or the pregnancies which are terminated due to some indication. Okay, so this is commonly falls in the group medical termination of pregnancy. Clear? Yes. Now, in this video, we are going to discuss about the isolated spontaneous abortions. Okay. Now, 80% of spontaneous abortion usually occur within 12 weeks. Right? And in the first trimester, usually there will be a fetal demise that will be followed by expulsion. Clear? Now we'll see some of the terminologies related to this. Okay. So some of the important terminologies that will be confusing. Okay. Number one is anembryonic miscarriage or pre-embryonic loss. So here there is no identifiable embryo at all, anembryonic, so no embryo. Okay, no embryo at all. Okay, no embryo identified. I'll just explain in simple terms. Okay, next one is a embryonic miscarriage or embryonic loss. Okay, that means there is an embryo but yes, no cardiac activity found. Right? And there is something called as biochemical pregnancy loss, which means there is a positive urine pregnancy test or a serum beta HCG, but there is no ultrasonogram confirmation of pregnancy. Clear? And next one is clinical miscarriage. So, clinical miscarriage means a pregnancy that was confirmed by ultrasonogram and then a loss has happened, right? So, a miscarriage after ultrasound confirmation. Clear? So these are the various terminologies. Okay. Now we'll see what are the various factors or causes that can lead to this spontaneous pregnancy loss. Okay. So what are the etiology causing this pregnancy loss? See, we can divide them into two broad categories. Okay. Number one is the fetal factors and number two is the maternal factors. Right. So we'll see one by one. Now the fetal factors include, number one is chromosomal abnormalities. Okay. Now very important, this category is going to top the all causes. Okay. Now in chromosomal abnormalities, usually we know there are trisomies and monosomies. Okay, say take trisomy and monosomy. And in trisomies, we have 21, 18 and 16, and monosomy X, which is Turner syndrome, which is the most common. See, among this, trisomy 21 is the most commonly occurring trisomy. Okay, and it is the most common cause of lethality also among trisomies, right? And but whenever trisomy 16 is going to happen, it is going to be lethal. So most common lethal trisomy is 16, because in trisomy 21 we have so many live births. Live births can happen, right? But if there is a trisomy 16, there is definitely going to be a lethality or miscarriage. Understood? And also, if you take trisomy and monosomy, which is the most specific chromosomal abnormality that will be leading to pregnancy loss, means that credit goes to monosomy. Clear? Okay, I hope I made these points clear. Now, we'll go to the structural anomalies. Okay, so second most common cause that can lead to fetal miscarriage from the fetal factor is structural anomalies. Clear? Now we'll see some maternal factors. There are lots of maternal factors. Okay, see, when the maternal age is more, suppose maternal age is more than 35 years, okay, or when she is a obese woman, obesity is there, okay, when she is a case of any chronic ailments like thyroid disorders, okay, or diabetes mellitus, okay, then hypertension. Also, there is an undiagnosed cyanotic congenital heart disease that is present. Not only this, when there is autoimmune causes also, for example, SLE, then any uterine anomalies, okay, say septic uterus, okay, or intrauterine adhesions, that is, yes, Asherman syndrome, intrauterine adhesions. Then there can be cervical insufficiency. See, these are some causes, and also you may include leiomyoma, okay, especially the submucous type, and sometimes even some placental causes, okay, there is a defective placentation like that, then that can also lead to miscarriage, okay. And some other causes include increased paternal age, okay. So increased paternal age can also be a risk factor, okay. Not only maternal age, increased paternal age can also be a risk factor, because there can be some chromosomal abnormalities in the spermatozoa, okay. Chromosomal abnormalities in spermatozoa, okay. And other than that, illicit drugs consumption, alcohol consumption, or even increased caffeine consumption. Okay, increased caffeine consumption, usually 2 regular cups of coffee can be allowed. Okay, 2 regular cups of coffee is allowed, but if it is more than 200 milligram per day of caffeine consumption per day, then it can also be a cause. Okay, and other things like infections. Okay, you know the torch infections. Okay, so what are the torch infections? It is toxoplasma, rubella, C for cytomegalovirus, and H for herpes virus. Sometimes this O can be considered separately, and you can even include chlamydia, brucella, ureaplasma, etc. Okay, and not only this, sometimes trauma, okay, and sometimes even subchorionic hemorrhage can also lead to pregnancy loss. Am I clear with the list? Yes, we have discussed so far, and the most important cause is chromosomal abnormalities, right? Okay. Now, we'll classify the chromosomal abnormalities. Now, we'll see what are the various types of spontaneous isolated miscarriages. Okay. So, spontaneous and isolated miscarriages can be classified accordingly into main types, and you can remember it by the mnemonic TIC MS. Okay, give a square to I. So, it is TIC MS. Okay, and remember it in the same order as I am teaching you, because that will help you to remember the findings also. Okay, so that is why I gave a mnemonic, that is TIC MS. Right, now we will see first what are the expansion of this. Threatened miscarriage, inevitable miscarriage, I is square, right? So, it is incomplete miscarriage, then complete miscarriage, then it can be missed miscarriage, and septic miscarriage. Clear? Yes. Now, we will learn one by one. First one is threatened miscarriage. Threatened miscarriage is a miscarriage in which there is a threatening to get the pregnancy loss. Okay, actually there is no pregnancy loss or something, but it is being threatened. Okay, the baby just threatens that it is going to come out, and it will be shown by a bleeding that will be coming through the cervical os. Otherwise, nothing happens, right? Now, we just see. So, the most important finding you will be able to appreciate in a threatened miscarriage is bleeding through the cervical os. Okay, and sometimes even there can be a suprapubic discomfort. Okay, low backache, or even cramps. Okay, and when you do an examination, when you do a per-abdomen examination, you will be able to appreciate a diffuse tenderness, and when you do a per-vaginal examination, you will be able to see the uterine size corresponds or equals to the period of gestation, because nothing has happened, only the bleeding has come out, right? But the whatever it is formed, the products formed are going to be inside the uterine cavity only. So, the uterine size will be corresponding to the period of gestation, and remember the cervical os also will be closed. Okay, the cervical os is closed and there will be no pain on cervical movement also if you do a pervaginal examination and see. Okay, but whenever threatened abortion is happening, okay, any kind of abortion or any kind of bleeding in early pregnancy, we are going to follow it up with the ultrasonogram also. So in that you will be able to appreciate that sometimes that is definitely the cervical os will be closed, okay, and the embryo is in the uterine cavity. Fetal heart rate plus, okay, fetal heartbeat will be there, okay. But remember, when this happens, you have to rule out ectopic, okay, and subchorionic hematoma, okay. But remember, when this happens, you have to rule out ectopic pregnancy, okay, and in some cases, you will be able to find subchorionic hematoma, okay. But however, this is not going to increase the miscarriage risk, okay. And then we will see the pic for better understanding, okay. So, if you see this pic, you will be able to appreciate that this is the uterus and this is the products of conception and this is the cervix, okay. Remember, the cervix os is going to be closed and there is only bleeding that is coming through the os. If you see, the fetal heart rate will be there and none of the products of conception will be expelled through the os. Clear? Now, this is another picture. See, so first point is os is closed, okay. The fetus or the embryo, it is completely inside the cavity, okay, and FHR will also be present. Clear? And only thing that has happened will be bleeding, which is an external manifestation that you will be able to appreciate, and otherwise the patient may complain of low backache or cramps or suprapubic discomfort, right? Now, what will be the advice you can give to the patient? See, generally you can advise her that regular follow-up is enough, okay. So, regular observation and for the cramps or pain, you can give her some analgesics, okay. Usually, bed rest is not advised completely. Complete bed rest is not advised because we fear DVT in cases of pregnancy, okay. Coitus to be avoided, okay. Suppose if the bleeding is continuing leading to anemia or hypovolemia, in this case, pregnancy evacuation can also be needed, okay. Now, if there is a threatened abortion, okay, it increases the risk of placental abruption and even preterm labor in later gestations. Clear? Yes. And next one is, what is the next one? Yes, it is the inevitable abortion. Inevitable abortion means there is nothing that can be done to stop the pregnancy from getting lost. Clear? We'll see. Like it comes to a stage, okay, there is a stage reached when the loss cannot be stopped, yes, and this may even proceed to a complete abortion, okay, may proceed to a complete abortion, okay. And usually the presentation will be with severe bleeding and cramping abdominal pains, Okay, and when you do an examination, you will be able to appreciate that the uterine size does not correspond to the gestational age. Okay, that means it is not equal to the gestational age. Okay, and the cervical os can be open. And sometimes when you do a pervaginal examination, the products of conception can be felt through the os. Clear? So, this is a case of inevitable abortion. Okay, see, there is an excessive amount of bleeding that is passing through the cervical os, and also the products of conception are also in the phase of expulsion, right? And nothing we can do about stopping this loss. So, this is another ultrasonogram. Pick to make it clearly understand. See, the os is open. The os is clearly open. Okay, and this is in the process of expulsion. Okay, usually it will come at the level of cervical os, or it may even protrude through the os. Okay. So, in the USG also you will be able to find the cervix is dilated, then G-sac can be seen at the level of cervix. Clear? Yes. And the next type of miscarriage is incomplete miscarriage. So, incomplete miscarriage. See, basically when there is a pregnancy loss that is happening before 10 weeks. Okay. Usually the fetus and the placenta will be expelled together. Okay. But later than this, when it happens, usually they can be delivered separately. Okay. So, some products of the conception can be retained inside the uterus. That is, retained products of conception can be seen in the uterine cavity. Okay, and it will be called as incomplete abortion. Clear? And if you see the symptoms, there will be a history of heavy bleeding, pain may be present, and sometimes this history of heavy bleeding can be also associated with history of passage of some products or tissue. Okay, if you ask the specific history, you will be able to differentiate it. And then when you do an examination, usually the uterus is smaller than the gestational age, because some of the products are going to pass out of the uterine cavity, and the cervical os may be open. Okay, and in this case also products of conception can be felt through the os. Okay, felt through the os. Clear? And when you take a ultrasonogram, okay, when you take a ultrasonogram, increased endometrial thickness will be noted. Okay, sometimes the endometrial cavity may even contain echogenic or heterogenic material. Sometimes vascularity can also be seen. Okay, so this vascularity checking is very important, because it will help you to differentiate from the blood clot also. Okay, and how will you manage this case? See, this is the picture first. First, let us see the picture. So, this is a case of incomplete abortion. Okay, so products, some of the products of see, the embryo is not seen. So, some of the products of conception has been already expelled. There is a heavy bleeding. Okay, and here some of the retained placental tissue or seen, and there is a feeding trophoblastic vessel, okay, meaning that it is the products of conception only and not a blood clot or something, right? Yes. Now, how will you manage this case? See, management is basically expected management, okay. Suppose if the products of conception are lying loosely in the os, now this can be extracted with ring forceps, okay, and even you can give some medical management like misoprostol can be given, or even you can go for surgical evacuation. When the mother becomes hemodynamically unstable, surgical method of evacuation can also be done, right? And next type of miscarriage is a complete miscarriage. So far from our discussion, I hope you would have understood what is complete miscarriage, right? So, products of conception has completely expelled out from the uterine cavity. That's it, okay? So, products of conception have been completely expelled out from the uterine cavity, okay. Now, here also there can be history of increased bleeding, okay, pain also increased, and there is history of passage of tissues also, okay. And what you will be able to appreciate in examination? So, during examination, if you do a per abdomen examination, definitely the uterus is going to be not equal, or it is going to be smaller than the gestational age, okay. And then the uterus is well contracted. Now tell me, how will be the cervical os? All the products of conception has been already expelled out. So what do you think about the cervical os? Yes, cervical os will be closed, okay. Now when you do ultrasonogram, there will be a thin endometrium only, okay, and you will not be appreciate even a G-sac, okay. So how will you confirm that a gross expulsion has happened? Yes, you have to confirm it grossly, okay, and you have to check for the products of conception, okay. Check if the true products of conception has been expelled, okay. And this should be ideally like there should be a USG documented pregnancy first, okay, and this should be followed by a USG documented empty uterine cavity. Clear? So, if you see this pic, you will be able to understand that there is nothing in the uterine cavity, okay, everything has already been expelled out and the cervical os is going to be closed, okay. And this is a complete abortion ultrasonogram where there is only a thin layer of the endometrial cavity, and there is nothing heterogenic or echogenic material that is seen in the uterine cavity. That means there is no products of conception inside. Clear? Yes. Next type of miscarriage is missed miscarriage. Okay. Now here the products of conception or the embryo has already died. Okay. So dead products of conception have been retained. in the cavity. Okay, and you have a closed cervical os. Okay, usually in this case there will be only minimal symptoms or no symptoms at all. When you do examination, uterus will not be palpable and fetal heart rate is not heard. Okay, we'll see some of the findings in detail. Okay, so the findings may include ultrasonogram findings. Okay, number 1, mean sac diameter is more than 25 millimeter. Okay, but there is absence of embryo. Okay, then second one, crown rib length is more than 7 millimeter, but there is absence of cardiac activity. Clear? Next one, initially you saw a ultrasonogram in which gestational sac, but there is no yolk sac. Okay, gestational sac minus yolk sac. Okay, that means you saw only the gestational sac, there was not even a yolk sac. And you repeat the scan after some 14 days or 2 weeks, then you see still the embryo or cardiac activity has not appeared. Okay, there is no embryo or cardiac activity. And another point is, initially you saw a scan where you were able to appreciate gestational sac and a yolk sac together. And you repeat the scan after some 10 to 11 days. Okay, then you will see a embryo alone. Okay, but no heartbeat seen. Clear? And another thing is, even a slower heart rate, that is less than 85 beats per minute, is said to be unfavorable for a good pregnancy. And sometimes an irregular sac can even indicate loss. Clear? So here if you see, this is a diagrammatic representation of a miscarriage where you will be able to see the products of conception in the uterine cavity. The os is not opened, but if you see, the fetus is not live. Okay, and also the same thing here. Okay, something is there, some products of conception is still in the uterine cavity, it has not been expelled, but definitely it is not alive, right? So that is a miscarriage. Now what you will be doing for this? How you will be managing this? Again you can go for a expectant management. Okay, you can go for a expectant management. You can do a medical management also. So medical management, first you can give mifepristone 200 milligram. Then after 1 to 2 days, you can give misoprostol, some 800 microgram per vaginally. Clear? We still have one type of abortion, that is septic abortion. See, septic abortion can arise as a complication of medical methods or surgical methods. Okay, arise as a complication of medical or surgical methods. Okay, usually the most common organism that is causing infection in septic abortion is Streptococcus pyogenes. Understood? And the features include, there can be complaints of high degree of fever, okay, lower abdominal pain, foul smelling, vaginal discharge, etc. Okay. Now, when this is going to happen, okay, septic abortion progresses in 3 stages, okay, or 3 grades. So, it can be grade 1, grade 2 or grade 3. What is going to happen in grade 1 is, okay, usually the endometrium is getting involved, okay, and in grade 2, that is endometrium of the uterus is getting involved, and in grade 2 it will be the adnexal tubes, ovary can get involved, and even sometimes the parametrium can also get involved, okay. And in grade 3 of septic miscarriage, there can be a generalized peritonitis can occur, and that can even result in a septic shock. Clear? So, this is how a septic abortion will progress. And on examination, if you see, generally there will be uterine tenderness, okay, and if you do a pervaginal examination, a cervical motion tenderness can also be appreciated, and yeah, a foul smelling discharge can also be a finding in examination. Yes. So, when you do an ultrasonogram, you will be able to appreciate the uterus will be enlarged. Because why? Because there is a collection of so many gases, okay, that will be collected due to the septic process, and there can even be shadowing, okay, when there is a gas forming organisms, and fluid can be appreciated in the pouch of Douglas, okay. Sometimes uterine perforation can also occur, okay. Now, how do you manage? Management is mostly by broad spectrum antibiotics. This is very important in the management also to limit the prognosis of infection, okay. Suppose it is a gram positive organism, you can give ampicillin or penicillin. When it is a gram negative organism, you can give gentamicin or ceftriaxone, and when there are anaerobes, you can give them clindamycin or metronidazole, okay. Suppose if you see any retained products of conception that has led to the sepsis process, then immediately suction and evacuation must be planned, okay. Suppose if the uterus has been involved extensively and the uterine necrosis has set in rare cases, that may even end up in hysterectomy, okay. So, what are the most common complications? Most common complications that occurs due to septic abortion may include some severe necrotizing infections, yes, then toxic shock syndrome that can occur by group A streptococcus, and sometimes maternal death can also occur if it is complicated by the infection by Clostridium species, say Clostridium perfringens or Sorteli. Clear? Yes, this is all about the different types of isolated spontaneous abortion. Okay. Now we will summarize all the types of abortion once to make it even more clear. So first one is threatened abortion. Next is inevitable abortion, incomplete abortion, complete abortion, and then missed abortion. Okay. Now first point is per abdomen examination, or we can start from the history. Okay. By history, there will be bleeding PV or pain abdomen, right? In inevitable abortion, there will be increased bleeding, okay, and maybe pain abdomen can also be present. Okay, that's all. And in incomplete abortion, what is going to happen is there is increased bleeding with some chori history of passage of products of conception, okay, and the bleeding can be more increased. And in complete abortion, definitely there is a bleeding plus expulsion of products of conception, okay, and later what is going to happen is after all these process has been done, the bleeding can get stopped, okay, before she comes to the clinic or hospital. And in a missed miscarriage, there is no history, okay, there is no history of anything that has happened, so like that, okay. So this is all about the history. Next, if we take the examination findings, first we will see the per abdomen findings. In threatened miscarriage, the height of the uterus, okay, I'll just mention it as US, that is uterine size, okay, uterine size corresponds to the period of gestational age, yes, and in inevitable miscarriage also, the uterine size is going to correspond to the gestational age, yes, and incomplete miscarriage, the uterine size will be definitely less than the gestational age, yes, and in complete miscarriage also, the uterine size is less than the gestational age. And a missed miscarriage also, the uterine size is generally less than the gestational age. So in the first two things, the uterine size corresponds to the gestational age, and in the last three things, the uterine size is less than the period of gestation or gestational age. Okay. And next one is we have to know about the internal laws. Okay. So internal laws is generally closed in a threatened miscarriage. Okay. And open in case of inevitable miscarriage, okay, and open with products of conception felt in the os in case of incomplete miscarriage, okay, and in a complete miscarriage, the expulsion would have already been completed and the os goes for closing again. So there is a closed os, and in missed miscarriage also the os is closed. Clear? Yes. And usually, what is the management we are going to give? Okay, so in threatened miscarriage, I have already told you we are going to one day observe and we are going to advise some regular things like coitus has to be avoided and bed rest is not that much needed, and only follow-up is needed. Okay, maybe we can write follow-up. Okay, and in incomplete inevitable miscarriage, it is already inevitable. Right, already inevitable, and I told you there is nothing that we can do to stop the miscarriage. So better we'll proceed with the miscarriage process, and we can help the mother by completing it by either medical or surgical means. So medical or surgical methods of management to complete the process. And in incomplete miscarriage also, we are going to help her by completing the process of abortion. So complete the process by medical methods or surgical methods, right? And in a complete miscarriage, already a miscarriage has been occurred, right? So we are just going to give her reassurance, okay, and give support to the mother, okay. And in missed miscarriage, we have to start it. We have to start the process of termination, okay. So we are going to give her a medical or surgical method of expelling the process. Clear? Yes. And one more thing I want you to make clear is, even then a miscarriage occurs, we should be careful about the blood group of the female, because in future she shouldn't get affected with RH alloimmunization, right? So, in a RH negative mother, anti-D should be given, okay? Especially in a case of threatened miscarriage, okay, it should be given after 12 weeks. And in case of incomplete miscarriage, inevitable and incomplete miscarriage, this can be given at a dose of 50 microgram when she is less than or equal to 12 weeks, and it can be given at a dose of 300 microgram when it is more than 12 weeks of gestational age, okay. And suppose if it is a complete miscarriage, you can give it the complete dose, that is 300 microgram, when she has expelled above 12 weeks, okay. And if it is a missed miscarriage also, you can give the dose of 50 microgram if she is less than 12 weeks, and if she is more than or equal to 12 weeks, you can give her some 300 microgram, okay. And yeah, so with this we'll be completing the discussion on miscarriage or abortions. So until we meet in the next video, take care, happy learning, and bye bye.